Welcome to Opt In with April Jasper. Relevant conversations about topics important to eye care providers today.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Hi everyone, I am here with Dr. Harvey Hanlen, one of my good friends, optometrist, past AOA president, but we are not in a place you might expect. Where are we, Harvey?
We are actually in Cambridge, England, at a conference called the Bond Conference, which is the Brain and Ocular Nutrition Conference.
It's awesome. I've never been here. It's a fabulous conference. John Nolan has done a really good job putting it together. And the science we're hearing is just incredible, wouldn't you say?
Oh, it's remarkable. We're with the leading scientists in the world, both from not only the United States, but all of Europe and Asia. And the speakers here are amazing. And, you know, as an optometrist, we're used to hearing regular lectures and about whether it's vitreous or whether it's retina or whatever. We're talking about the leading science in the world.
Yeah, it's incredible. So we've had a day. We're moving into the next day. We actually had some fun yesterday, too. We went punting.
Yes. Well, let me tell you what punting is, because I had to look it up. I had no idea. Punting basically is like being on a gondola, and it's a boat, and it goes. We were on the Cam River, or I guess that's what they call it, a river. And we actually could see all of the University of Cambridge schools here and colleges. It was remarkable. We had a lot of fun.
Yeah. We did. It was great. But you know what's also really cool is just to see this community get together, meaning all of these scientists. Harvey and I are the ones, well, I'll speak for myself, Harvey. I really don't fit in at all, but I sure love hearing them. And what we're going to give you more of as the podcast goes on is more of what they've done, their research, and then how it applies to us in practice. What stands out to you so far?
Well, I think what I've realized, and I've been involved in this as a consultant with MacuHealth for a few years, and having done some lectures with John Nolan, is the amazing science that's going on and what we're finding out about not only how things affect our vision, specifically different carotenoids and the combination of carotenoids, but also the effect that it has on other diseases, specifically dementia and Alzheimer's, which I'm amazed at.
Absolutely. I think the time is here for me. It's always been this way, but even more so now, where I'm ready to really just talk to patients about prevention. I want them to know there are things they can do that will help to make a difference, because everybody's been touched in some way by these diseases, whether they're eye diseases or brain diseases. And this conference brings it all together, because after all, the eye is part of the brain.
Exactly. I think what we learn over time, and I've been in practice for 48 years and just have retired from patient care, but I think I've learned more about the science in the last number of years. And I think as an optometrist, if we always take care of our patients based on evidence-based science and what's best for them, that's really the answer.
I love it. Well, you guys are going to enjoy this. We're going to have other folks come in and kind of talk about what they have done in research. These folks, they put their lives into research, and they don't do it just so they can put their name on a paper. They do it so they can make a difference for us. So I hope you enjoy what you're about to hear. Thank you, Harvey.
Thank you for having me. I appreciate it.
Dr. Imre lengyel, thank you so much for being here with us. I'm so excited for you to bring your presentation to everyone that watches and listens to our podcast. So let's start with you telling everyone a little bit about yourself.
Okay, so I'm a reader. In American terms, it's an associate professor at Queen's University Belfast, where we do a lot of translational research. And my program is involved in the eye translational research. So I'm a basic scientist wanting to take the observations we make in the microscopes and in the bench to the bedside, and therefore we do both bench work and then clinical work as well.
Wow. So tell us, your presentation was phenomenal. Tell me and all of our listeners a little bit more in a shorter period of time about what work you've been doing and what you presented here this weekend.
So I'm particularly interested in how disease starts. As you all know, problems with age-related macular degeneration or Alzheimer's disease, at the moment we are trying to treat the disease, which is as successful as it is currently. So going a little bit more in time earlier means that we would need to understand what happens earlier. And that's my focus, and I brought together Alzheimer's disease and age-related macular degeneration through the extracellular deposit formation, which happens in both diseases, but looking at the eye. And what we discovered a few years ago is that these extracellular deposits, which most people would understand to be called drusen, has a mineral core. And this mineral is calcium and phosphate containing, which is your teeth and your bone. So obviously something that you don't want in the back of the eye. And when we started to understand how widespread this is, basically we haven't seen any deposits in the back of the eye without calcium deposition. But we also discovered in a big international collaborations with other speakers at this conference, like Christine Curcio, that one form is particularly bad for patients with age-related macular degeneration. We call them nodules, which are made of hydroxyapatite purely. And what it does, it basically grows very relatively rapidly and destroys one of the most important cells in age-related macular degeneration called retinal pigment epithelium. Because once that's destroyed, the retina is directly exposed to any insults, and it also interferes with the transport. So what was the major finding of that study is when you have these big calcified deposits, that is associated with a rapid progression to end-stage disease. And what it suggests to us that stopping that developing or growing or go just a little bit earlier to stop its growth to a much bigger size that produces so much problem, that would be a very beneficial for the patients.
So the clinical significance, and by the way, if anyone can look up your papers and see the images, they are incredible. That was one of the most interesting parts, and I think that made it even more impactful, is to actually see what you've been able to discover. But let's go to now clinical significance. What can everybody take from what you're finding, and how can they apply that to seeing patients in practice?
So I think it's a very interesting question how early we could detect these calcifications. And when we take this to the microscope, we see these calcifications appearing very early on in disease without drusen, without any damage. That suggests that if we can visualize this early, and that would help us to identify the point when we might be able to interfere with their growth.
Wow.
So what we are working on is developing sensors that would be able to help us detect in the living eye these deposits, and we are making quite good progress with an international collaboration again. The second step will be to understand, once we have it, what can we do to either stop it or at least slow down the progression of these deposits. So for a clinician, if we were able to detect early, then we would be able to advise patients that this is happening.
Yep.
Because these little calcifications, if they are really what we believe is the seed, one of the seeds at least, to the deposition, then what we can do is visualize this much before it becomes clinically visible.
And what will they do? So what are you thinking right now?
Well, this is a very important question, and I wish I would have a very clear answer to that, because calcification, just like as you would expect from your bone and teeth, it's very, very difficult to dissolve. So once it's there, it's probably going to be harder to remove it than stopping developing.
Right.
Currently, we don't have fantastic therapies, but on other diseases like scleroderma or pseudoxanthoma elasticum or heart calcification, there are approaches where people are trying to use actually nutritional supplements, like increasing pyrophosphate levels, which is an inhibitor of calcification and naturally circulating in the blood. There are very good efforts on these rare diseases to introduce these substances to slow the calcification disease.
You kind of talked about what you're doing next, but go ahead and tell us a little bit more. What are you working on now, and how soon will we have some more information? How we often don't realize how much work, and let me just tell you right now, thank you from everyone that, a lot of us don't have any idea how much goes into discovery and research and new treatments. So a big thank you from all of us, but also we are impatient. We don't realize this takes time. How much time are we looking at before we start to be able to see the next step?
So unfortunately, science is complicated because taking any treatment to a patient takes quite the need to build up a very good understanding of the biology behind. But what we are trying to do is in the last few years we developed cellular models that produce calcification, and that is the first step to manipulate the process.
Right.
So we are very, very excited about that we are able to do that in a cell culture. Now we are starting to understand how to speed up the process so we can interfere.
Yes.
And also how to stop even the development. So this is a major step before you can go to a clinical trial.
Yep.
But we also identified some specific animal models that produce calcification in the eye, and that's again giving us the preclinical opportunity to study how could we interfere with this process. So these are very, very important steps, but it's probably a few years before we could come up with an idea of how to interfere. However, and I think that's why this conference, for example, is so important, there are many different diseases and there are many different factors of these diseases that we can take advantage of. So being able to talk to our colleagues about what they do in different diseases, how interaction between different nutrients could help, because these are the things that we can do now, advising people once we get the result is if we don't need to develop new drugs because these are naturally available. So there is a bit of a hope in hell, and one thing is absolutely important, that this is a mineralization, and that means that there is calcium and phosphate that does something what they are not supposed to do.
Right.
But I often get the question, and that's why I'm raising this, that should we stop drinking milk?
Oh boy.
Or eat cheese, which have a lot of calcium? And the answer is no. This is a much more complex process, and it's not a single factor that we need to look for. So hopefully, gradually with these models, we will be able to get the answer how to slow the progression, which then we can take it to clinical trials.
Wow, this is incredible. Thank you for sharing with us. It's so important, the work you're doing, and I love that you're willing to bring it to everyone else and help us to understand better what's coming next. We look forward to it. I know all our listeners are as impatient as I am, but we understand there's a lot that goes into it, so thank you.
Thank you very much. It was a pleasure.
Hi, everyone. I'm here with Dr. Mark Roark, and we are here to talk about nutrition. So let's get started with the fact that you're an optometrist like me. We're both at this meeting together. What brought you here to the Brain and Ocular Nutrition Conference?
I've had an interest in nutrition for a long time. I was here at the 2018, actually was able to present about macrocarotenoids and contrast sensitivity there. And then the information presented here from researchers is extremely important because we can take that information, apply it in our practice to our patients so they can benefit from this information. Because if nobody really takes this from the research lab and puts it into the clinic, into our offices, we don't really benefit from all this great, wonderful information.
Right. Well, what's different, though, about Mark is that he not only is here attending and listening like I am, but he's also a presenter. So tell us about your practice and then tell us a little bit about your presentation.
Okay. I'm in a private practice I do have an associate in Fishers, Indiana, and it's a primary care practice. We do have a special focus on nutrition. So we talk a lot about, the benefit and the kind of connection between nutrition and vision, and nutrition and eye health. So we've done that for a number of years. We've done macrocarotenoid testing, did the densitometer testing for a while. We've actually gone now to a skin carotenoid scan that we do. We measure contrast sensitivity, listen to patients in terms of what they notice with their vision, and try to give them good advice about what type of nutritional supplement, and certainly diet. Diet's first.
Right.
There's no substitute for a diet. A supplement is not a substitute. It is a supplement. So we find many patients are low in their macrocarotenoid levels, and their nutrition status is less than ideal. So we talk about ways to make it better, specifically with pictures and information and handouts. And then we also address supplementation commonly. So I am a MacuHealth user. I love the triple carotenoid. I think it's got great science behind it, and it just works. And it's been had a great impact on patient care, patient outcomes, good feedback from patients who've used it. And we're seeing those numbers go up, and our contrast sensitivity is improving. We see our skin carotenoid scans increasing and good things. And so we're also trying to implement kind of a similar strategy with the use of omega-3, which was what I spoke about here.
That's what you spoke about here. So.
Right. So another really great nutrient with unique molecules. There's been about 50 years since the excitement began with omega-3s, and over 30,000 publications and research on these unique molecules. So we're still learning. There's more to learn, but we want to take some of what's been studied and research has found, and again, turn it into real-world recommendations for patients. So I had the opportunity of speaking on the role of long-chain omega-3s, polyunsaturated fatty acids in ocular health and disease, which is a big topic to cover in 35 minutes.
He did a great job,
to say the least. So we talked about dry eye disease, glaucoma, diabetic retinopathy, and AMD, kind of bringing people up a little bit to the most recent research we have, observational studies, RCTs, and practical applications of how to make this work in your practice.
So what you're telling us is that this is an option, or it's actually a good option, and it makes a difference for our patients with all four of those diseases.
It is definitely something that has a place. Nutrition does have a place in all four of those places. I think dry eye disease, many people are aware of. And there's a lot of use of various nutritional supplements, omega-3, omega-6, within the dry eye disease field. I personally think that you want to start with a really good omega-3, get those levels up, hit that greater than 8% mark on a blood test. So we take a drop of blood and send it on a dried blood spot card to a lab in South Dakota. And within about 10 days, we have a number that tells us whether those body tissue levels of omega-3 are in the right range, which is above 8% to 12. So that's what we're shooting for.
Okay.
So patients who fall short, who have any of those diseases, we're going to recommend they increase their level of fatty fish, which is great. So the diet again is, when I recommend patient eats or ask them if they eat fish, I get a lot of turned up noses and different comments, not of which too many are really eating that much fish, it seems, in Indiana these days. So we do talk a lot about supplementation as well to try to reach the goal. Again, I use TG omega-3 and I like it for a reason. It has a balance between EPA and DHA. So there's a lot of talk about ratios.
Yes, tell us.
Ratios. Well, where does that information come from? First of all, we don't have head-to-head comparisons between different ratios across these diseases. So, we're kind of going out a little bit of a limb if we make assumptions about that.
Right.
And we also know that there's no conversion, very little conversion, first of all, between things like walnuts and flaxseed. So if you don't get enough long-chain omega-3s directly in your diet, you just will likely be low.
Right.
So secondly, we know because when you get EPA, it doesn't convert to DHA. They don't go back and forth much, so at all. So you just need plenty of both. And the body then is amazing because it knows what to do. Just give it the ingredients, give it the building blocks,
Right.
put it in your diet, swallow your supplements. Usually start with around 2 grams a day for most patients in a EPA, DHA, esterified triglyceride formula. And then we monitor response clinically with blood work. And that's the approach I've taken now for a while, and it's working well. So we like that product, and it seems it's very well tolerated by patients.
So I didn't tell you ahead of time I had this question because I forgot, but here it is. And I know you're awesome at this and you would be a great help to all of us. But what does that conversation sound like with a patient? So a patient's there, they need it, and maybe even carotenoids. So let's talk both. And does it all come out at once? So a patient has AMD. And let's say it's drusen, but nothing that I would call moderate or severe.
Okay.
And we also know they have diabetes. How are you going to have a conversation with them?
So sometimes we find patients have multiple conditions, and there's a lot to talk about.
Yeah, I know.
So you want to be efficient.
Right.
You don't want to overwhelm. That's challenging sometimes. But I basically point to what we found. So if we find, I show patients photographs. We do a lot of Optimap.
Yeah.
So I can show the patient what I'm finding, describe why it's concerning, talk about how our lifestyle modifications, the choices we make can impact that to prevent it from getting worse or progressing. And then we can talk specifics. So your skin carotenoid score was 20,000. We'd like at least twice that. We'd really like 50,000. That tells me you don't have enough nutrients. So here's the vegetables I think you should start eating more of. Dark leafy green vegetables, spinach, kale, orange bell peppers. Are you doing that? You need to do that.
We learned about that, by the way, here this weekend. Orange bell peppers.
Yes, orange bell peppers, the way to go. And then along with that, because we want to make sure those levels of macropigments are elevated, that filter that's so important to protect the eye from antioxidant damage over time and filter blue light, provide all these benefits even to vision. We want to make sure that's dense. So how can we do that? I have a brochure I usually pull out, and here's an eye with very little pigment, potential for damage over time, and here's an eye that's got nice, dense, restored pigment. This is what we want your eye to look like because you're getting that protection. And what does that mean? That can reduce your risk of losing vision because we know those nutrients are so important. So along with the macrocarotenoids, we also know omega-3s are quite important. And based on what you've told me about your diet, perhaps, and maybe other findings I have, we know diabetic patients, they need omega-3s. The eyes are inflamed. We want to calm that inflammation down. Again, so we have a test we can do with a drop of blood. It's kind of like that skin carotenoids test for the macrocarotenoids. It tells us whether your body tissue levels are adequate, and we can titrate the dose. We would start with maybe three to 4 a day, so around 2 grams if you're not eating any fish. And we can do the baseline test today, have you come back. We can see how things are looking clinically. We can see how you're responding to things. We can titrate the dose. So we have ways that we can see how you're responding objectively. But our goal here is to reduce the risk of disease, reduce the risk of it coming or progressing to more serious things that impact our ability of our eyes to be comfortable or for us to see clearly. And people are living longer now. So we have the future to look to. And the people I think who do the best are those who have the mindset they're going to start doing this and do it consistently. It's not like I'm going to still bottle this and change my diet for a week or a few weeks. It's got to be a longer term decision for it to really have the impact we want.
Right. I love that. And one of the things that we really all have been focusing on more, I think, in our practice is prevention. So we talked about the patient who has a problem, but now you've got a patient that comes in that doesn't have any eye disease to be seen in a photograph, but at the same time is possibly at risk for other reasons. Do you talk about this with everybody, or is it just the patients that you see active issues with?
Yeah, that's a good question. I mean, it tends to be a lot of people, because if you take a look at your patient base, at least my patient base, between those 4 diseases we talked about,
Yep.
that's quite a few people, especially the dry eye. If you
Right.
really look with my biography and you put some dye in the eye and you talk to patients, you'll find a large percentage of your patients have dry eye. So you're already
Good point.
automatically going to be talking about omega-3s in my practice. And then if you have a family history,
Right.
if you complain of glare at night, if you have poor contrast sensitivity, if you have a low skin carotenoid scan,
Yeah.
if you have early signs of macular changes, pigmentary migration, these are all things that are going to lead that discussion right into the nutrition realm. So I do find that many patients who aren't necessarily complaining or mentioning anything as far as the reasons to discuss nutrition, because we gather information that tells us about the status of the patient, it does enable that conversation to flow pretty easily and naturally. And I think patients do appreciate you're addressing something that they're not really hearing from many other providers.
I love this. Thank you so much, Mark. I knew you would bring this all back to what do we need to do in the office. And a few tips that he gave us. You heard contrast sensitivity. You heard glare, so complaining of glare.
Complaints of glare.
And you're measuring this. So there's a lot of things that we could be doing to find these issues and start a conversation. So
Absolutely. Yeah, I think that's helping the patients. They're
Yeah.
there in our office.
yeah,
We have an opportunity for a limited time to understand where they are nutritionally as well, and then have that conversation and try to do something positive. So patient outcomes, long-term patients are seeing better and
Right.
healthy eyes, better vision. That's our goal.
and a lot of the conversation has been around Alzheimer's. And, I
It
mean,
has been.
what do you think about the fact that we are treating eye disease, but this conference is called Brain and Ocular Nutrition for a reason? What is that all about?
Yeah, so there's this connection. So we know that there's a correlation between the amount of pigment in your macula and the amount in the occipital cortex. So as you increase the level through your diet in the eye, it's increasing in the brain. Some studies indicating better memory, recollection, those things. We know the effects of omega-3. We just heard this morning about Alzheimer's disease and the importance of DHA. So I think we have so much more to learn, but I think you can't go wrong with adopting a healthy lifestyle with plenty of fruits and veggies, and supplementing with Macu Health and often TG omega-3. Those work really well together. They complement one another. So I tell patients Macu Health works best in the presence of healthy fat. This omega-3 is healthy fat. Take them together.
Love it. I love it. All right. Lots of good advice. And we appreciate you, Mark. Thanks for spending time with us.
Thank you very much for the opportunity.
Hi, everyone. I'm here with Dr. Paul Bernstein. And you know what? I have to immediately say, you've got to help me with this all weekend, Dr. Bernstein. And this is really incredible. First of all, you are so famous, and it's such a pleasure to have you here. And I know all of our listeners are just going to be thrilled to hear what you're doing these days. So let's say thank you first, and I appreciate you so much. But here's what has been confusing to me. It's not just the carotenoids and all of the omegas and all of what's going on with that, but also I don't know who to call doctor and professor, and you just told me something about mister. What's the deal with all this?
Okay, so we're not in America here. We're in England, and I've learned through the years the prestige of various things. And doctor is a very prestigious title in the United States. Here in England, I prefer to be called professor. That's a higher rank. And very interestingly, a lot of Americans don't know that Mr. is a very prestigious rank here. That means if you're in the medical field, that means you're a surgeon. And so many people prefer to be called Mr. rather than doctor.
Wow, that is so. I should have asked the question ahead of time, like 2 days ago, but thank you for clearing that up for me. And I love little tidbits of information I learn along the way. But what we want to do today is first, I want you to tell everybody more about you, because there are some of us that see patients all the time. We know that behind the scenes, there's a lot of research going on, and there's a lot of people learning about and discovering what we need to do to take better care of our patients. But I didn't always know how that happened and who was doing that. So tell us about you and a little bit about how you merged that into practice as well.
Certainly. So I'm a professor of ophthalmology at the Marina Eye Center of the University of Utah, and I'm a retina specialist, and I'm clinically trained. I'm a surgeon, and I see patients, and I also run a research laboratory. So I'm a clinician scientist. I do it all. And I've been working in the field of nutritional biochemistry for the eye essentially all of my career, dating back to my PhD work on vitamin A metabolism in the eye, through my postdoctoral work starting on carotenoids, and continuing on since I've been on the faculty at the Marina Eye Center for 27 years. Wow. I've been working on trying to put good basic science behind nutritional recommendations for the eye, with a lot of focus on carotenoids, lutein and zeaxanthin that we all consume in our diet, but and that are specifically concentrated in the retina of the eye. And that's been a focus of mine, is trying to study nutrients that are targeted to the eye, because that nature is trying to tell us something.
Absolutely.
And I've been continuing on that work, and lately I've been expanding into the omega-3 fatty acids, especially what are called very long-chain polyunsaturated fatty acids, as a new generation of supplements for the eye. And I've been working not only with a basic science laboratory, but I do clinical research on all of these compounds. I was an investigator for the AREDS2 study, and we're in talks even of what should be the next generation of AREDS3.
Right. I love that. So tell us about what you presented on this weekend.
Okay. So we all know as eye care professionals the importance of lutein and zeaxanthin and potentially omega-3 fatty acids late in life for age-related macular degeneration. But there's so much more. And really, I'm trying to look at the role of nutrition in the eyes across the lifespan. And so I expanded upon my work on elderly by now focusing on what should we be doing early in life. And I'm talking really early in life. We've just completed a study called the LZIP study, which is looking at lutein and zeaxanthin in pregnancy and whether it should be added into prenatal vitamins, and can it prevent nutritional depletion that's occurring in the mothers during the last trimester of pregnancy when she's passing the nutrients on to her developing child, and can we influence the nutritional status, specifically carotenoids, in her baby by actually measuring the baby's skin, eyes, and serum within 2 weeks of birth. And we have exciting results that it really does change at least the baby's status. We will need to go back and look at these babies 4 years from now, see if they see better and if they're smarter. We don't know that yet, but we'll find out. With the mothers, we found that they didn't get quite as depleted as we thought they would be. But because this study was conducted during COVID, the people I could recruit tended to be hospital employees who tended to be pretty nutritionally aware.
Right.
So we need to go back and look at a more nutritionally compromised study, but compromised population. But we were able to show it was safe, that we had very good compliance, and that there's a lot of interest in looking at things early in life.
Wow. So you sort of mentioned already the clinical significance of this. Anything you would like to add, though?
Yeah. Well, we're also looking to see if it may be helpful in preventing eye diseases of the newborns. So even retinopathy of prematurity. We have some interesting preclinical data that lutein and zeaxanthin may have an effect in some selected animal models of oxygen-induced retinopathy. So that's where the carotenoids are going. I also talked about very long-chain polyunsaturated fatty acids, which is a nutrient that people are not so familiar with. Right. They are made specifically in the eye from the more common long-chain fatty acids like DHA and EPA that we get from fish oil. But they're made specifically in the eye. If there are deficiencies in an enzyme that makes these, you get a form of dominant Stargardt disease. And we've found that there are low levels in age-related macular degeneration and diabetic retinopathy. And with the chemistry department at University of Utah, we figured out how to make these in at least gram quantities now, and we'd love to scale up to kilogram quantities and see if directly supplying these very long-chain fatty acids that we don't normally eat in our diet, unless you eat retinas for lunch, which most people don't. And but we're looking to see if this could be a new generation supplement. We have some exciting data that will be coming out soon.
Wow. All right. So here's the frustrating part for those of us that hear this. We want to have this access to something like this right away. How long is it going to take? And maybe you can't give us real answers, but how long does it typically take from you discovering something is beneficial to us being able to have it for our patients?
It depends. Nutritional supplements sometimes can come through a little bit faster, maybe 5 years. If we have to go through getting grants and getting funding, and if it comes out that it has to be more like a drug, that's 5 to 10 years. So it's a long process, but if we don't start now, then it's even longer.
That's right. I'm just glad you're in the middle of it. I'm glad you're doing it. It's going to be such an impact on all of our patients, and who knows, we don't, any of us want to have issues ourselves, but we don't know that. So what's next?
What's next? Well, we are looking at continuing to do basic science and try to get good, more solid data to support this. And I've got a newer clinical study that we have coming up called the Magenta study, which stands for the Moran AMD Genetic Testing Assessment Study. And we are looking at the role of genetic testing, whether it's important as eye care professionals to test people at risk for macular degeneration, perhaps because they have a family history,
right,
and see if we can inform them. If we inform them of their risk, will that cause quantifiable changes in their lifestyle, so that we should to decide whether or not we should be doing testing? Because currently, the American Academy of Ophthalmology says, do not test patients because there's nothing they're going to do. Well, no one's ever actually never proven that. That's
right.
just some experts saying we don't think they do. So I've been able to get funding to do this study, to enroll patients and really assess them and try to put good clinical science behind this, and using ways of assessing lifestyle changes, not just doing surveys, but biomarkers, measuring carotenoids in the skin and the eye, and see if people make a change within a year.
Wow, that is so incredible. Dr. Paul Bernstein, thank you so much for being here, for sharing the information, and then talking to me so we can bring it to everyone who wasn't able to be here this weekend.
Thank you for having me here. It's been a wonderful meeting.
Hi, everyone. I'm Dr. April Jasper. I'm here with Dr. Emmanuel Addo, and I'm so excited to be here with him. Thank you for being here to talk to all of our listeners.
It's a pleasure having me.
So we're at the Bond Conference in Cambridge, and I want for you, Dr. Addo, to tell everybody a little bit about yourself, and then we'll talk about your presentation.
All right, thanks. Like you said, I'm Emmanuel Addo, and I am trained as an optometrist from Ghana, and moved to the U.S. for my graduate studies. And so currently with Dr. Bernstein at the Salt Lake City, he practices with the Marina Eye Center. And so that's how the journey has been.
Oh, that's wonderful. So what are you currently, well, first let's start with what was your presentation about here this weekend?
Oh, wow, that's awesome. We talked about the clinical trial I more or less engaged in, which is part of my PhD studies. And so essentially it's about lutein and zeaxanthin in pregnancy.
Yeah.
It's known that during the third trimester of pregnancy, there's a massive transfer from the mothers to their babies to support developmental processes. But this puts mothers at risk of systemic and ocular depletion. And if you're ever aware with the literature, AMD, it's more predominant in women than it is in male. And we think that could also be a potential reason for that increments in women.
Wow.
That's because the number of children they give birth to potentially deplete their store in the eye. And so we're trying to find out if supplementing mothers with these carotenoids could boost their levels in their systemic, that's their blood and their skin, as well as in their eye tissue.
So is this research ongoing? It's not finished?
Currently we are done, but then with any research, it gives room to look at other opportunities, to look at other areas that it can answer and be of help to humanity. And so technically we are done with LZIP 1, but we're looking forward to LZIP 2. And that might be in high-risk pregnancy.
Wow. So imagine now, mother has a baby before they reach that last trimester. Then what? What's happening to the baby? Because the baby didn't have that transfer. So is that something you guys are?
Yes, so we actually are looking at that because with the high risk pregnancy, it's quite challenging because most of these individuals develop, like, give birth preterm, and they miss that essential moment where most of these nutrients, which are crucial for babies' neural and visual development, do not get passed on to them, and they have to stay in the intensive care for a long period of time, and even develop some complications in their eye, like retinopathy of prematurity, which is the leading cause of preventable blindness. And so we're trying to find a means where we can intervene way earlier and probably see if we can, with the help of these carotenoids, which they take their normal prenatal standard of care nutrients.
Right.
So addition of these carotenoids to them could potentially help them. So that's what we hope to achieve with the second study.
So what happens next? So you did the first study. You know that it does transfer. That's the critical period of time. You know that it could put mothers at risk down the road for AMD. So what happens now? You're going to move into clinical research to actually try and see if it makes a difference?
That's good. And so with this, like with any clinical trial, it's in different phases.
Yes.
So with this, it's more like a phase 2 where we're trying to figure out if our hypothesis really is solid.
Got it.
And thankfully, we've been able to demonstrate that these carotenoids increases maternal and infant carotenoids level.
Wow.
And so the next stage is to find out what kind of dose would be appropriate, and does it even have any toxic levels that can endanger the life of these individuals. And so that's what we're looking forward to achieving, and we're excited about that.
Yes, you should be, Dr. Addo. That's amazing. You know what? Without you being here to actually show and tell people what this is all about, we wouldn't all know. It would be years before we get the information. So this is absolutely incredible. Thank you for all you're doing.
You're welcome.
And thank you for bringing the knowledge to us.
You're welcome. My pleasure. And I guess that's what science is. We've been able to make what we do known to the community so that they can be well informed. If there's any intervention, they can actually be proactive and prevent what needs to be prevented in a timely manner. So we are happy with what we're doing, and hopefully we'll be able to get something meaningful out there to
I love it. Thank you.
Inform all the people we meet with. Yeah, you're welcome.
Hi, everyone. I'm here at the Bond Conference with Professor Torbert Rocheford, and he is going to tell us about his presentation today and its clinical relevance to us in the world, honestly, but also in practice. Professor, welcome. We're so glad you're here.
Okay, so I'm in corn breeding, and I work for a period of time of breeding for higher levels of provitamin A in sub-Saharan Africa, where you have 250,000 to 500,000 children go blind or die every year from vitamin A deficiencies.
Wow.
So I worked on that for a good long while. And then we developed materials, and the organization I worked with was Harvest Plus. And the administrators from Harvest Plus were talking to the Minister of Health or Agriculture or both in Zambia, and they asked, you want us to grow and eat this orange corn. Do you grow and eat it in the USA? And the answer, unfortunately, was no.
Oh, wow.
So then they were like, why not? Is this second rate? It's not good enough for you.
Right.
So I was going to grow 1 acre of corn and give some away to chefs and maybe do a couple educational school lunches. Because if we ate 1, 10, 100 pounds, we could say, yes, we eat orange corn in the USA. The only quote-unquote problem was that it tasted really good. And I had Southerners say, this is the best grits I ever had.
Wow.
This is the best cornmeal I ever had. So long story short, we formed a startup company, but part of that, I came to this meeting because I was thinking about doing something for the USA. The university was encouraging me to get this technology out, but I had very small scale ideas, work with some organic farmers and sell some at a farmer's market.
Right.
Just say, okay, yeah, we sell it, we buy it, people eat it. Just hobby scale. I came to this meeting and learned about macular degeneration. I was Googling carotenoids, and there was this macular carotenoids meeting, and I didn't even know what macular carotenoids were. And the only problem was I was going with a group of scientists to like testify to this high-level Chinese committee that was considering what we call biofortification, making crops that people eat more nutritious.
Right.
You know, they're going to eat corn in Africa. They're not going to eat carrots. And carrots don't grow that well in parts of Zambia. So I came back from that, and then the next day I flew here, and I was totally jet lagged. But if I just came for 4 hours, it was worth it because dementia, association with carotenoid levels, age-related macular degeneration, cognitive function. This is 2015.
Right.
So I went back, and my son and I, really, the end of that month, we formed a startup company. We started writing federal grants, and we've been very successful. So in the U.S., we have milled products. You can get them on Amazon, and we use the brand Professor Torbert's orange corn. It's sort of like Orville Redenbacher. His popcorn. He's from Indiana. He went to Purdue. And Burt's Bees, you know, they have an association. And it's not like a personal thing that I wanted this, but I want the products to sell and the company to succeed. So we have that, and then we're developing orange popcorn. We're developing orange sweet corn. But we think the real big opportunity is with feeding orange corn to poultry, because it puts lutein and zeaxanthin and some beta-cryptoxanthin in the eggs. It's a highly bioavailable medium, and we produce 7 billion eggs a month in the U.S.
Wow.
So it's a big, we could penetrate 1% of that. Can you imagine what that would be? I can't even do the math on the top of my head, but it's a lot. So that's kind of the transition. Work that I did for Africa, the genes, the alleles, are being used quite successfully to increase provitamin A. So I've kind of done that thing, and now I'm doing things in the U.S.
So what was the result of the work in Africa?
Well, they've been able to increase provitamin A levels dramatically. They did an efficacy study in Zambia, which I will show a video clip from some of that my older son did when he traveled with me there. And they did show that you could improve serum retinol levels in response to eating provitamin A maize. And then they're working on education delivery and getting a lot of the breeding's been done, and they have the materials. Now it's delivery. Zambia was a target country. Now they've expanded to Ethiopia, Nigeria, Ghana. Yeah.
So I heard earlier today somebody talk about how when you change the color of products, that sometimes people are resistant to eating them because they look different. And I heard a response from you. So what is your suggestion? And it's helpful to us in practice because sometimes we're trying to get patients to understand and do something that's different. So you had a response as to how to get past that barrier. What was your response?
Well, it's education. It's education and target the mothers. The mothers care very much about their children.
Yes.
And they want what's best for their children. So they will listen. And the men, well, hopefully they'll listen too. But you're better off targeting the mothers.
Yep.
And then with vitamin A deficiency, though, it's not only the mothers because they have children, but pregnant and nursing women are having increased risks of serious effects of vitamin A deficiency. So they're subject and they will benefit from it as well. So you just have to have education. You have to be persistent. But in my talk today, I have a slide, and what it says is you have these orange grits and you tell children it tastes good, and they'll eat it and they'll say it hey, this tastes good, I like it, and they do like it. Then you tell them it's good for you. Because if you told them it's good for you, eat it, they're not going to want to eat it.
Right.
You know, it's like, here, spinach, it's good for you. It tastes horrible, you know.
Let them taste it
So
first.
it's education and persistence, and yeah.
I love that. And you know what? We're so used to cheese grits where we're from that if we saw orange grits, we would just think they're cheese grits. We'd eat them anyway.
Well, and from a dietary nutrition standpoint, you don't have to put a lot of cheese. Like some grits basically are just holding the fat. They have to put tons of cheese into it. You really don't have to put cheese in. You can put some in, and some people just love having some cheese in it. But you don't need to have. It does have some of its own flavors, and that comes from the carotenoids.
You're making us want to make sure we can go out and buy some grits that have these extra nutritional value in them right away. So when will we have access to it?
Well, you can go to Amazon right now. I was actually giving a talk. And a while back, and I told people, and someone came up to me and said, sorry for taking my phone out because you said put your phones away. And I ordered my father a bag of orange grits because he loves grits, and it was already on. So you can go to Amazon.
What are they called?
Well, you would write orange grits. It's Professor Torbert's orange grits. But all you have to do is go to Amazon, orange grits, and it'll look for Professor Torbert's. It'll come up.
Wow. And the nutritional benefit, you said? Tell us again one more time.
So it's higher in lutein and zeaxanthin, which is good for eye health. It also has some other carotenoids in it, like beta-cryptoxanthin, which is just a good antioxidant. So that would be the primary benefit. But as we study all carotenoids, we learn about their benefits.
Yes.
You know, we used to just know about beta-carotene. Now we know about lutein and zeaxanthin. Yeah.
It's incredible. And you wore your orange shirt today, so well done.
I did. But, you know, my son, who if you go to Amazon and you look at it, he does all the marketing and all that. I don't wear orange when we're doing photo ops because an orange ear doesn't look as orange in front of an orange shirt, but in front of a white or a blue does. But yeah, my son was a Forbes 30 for 30, Young Entrepreneur Awardee.
Wow.
And then GoDaddy picked up on him, and they did a marketing campaign, and they redid our website.
Wow.
So it's been good, and I get to work with my son. And when we were starting the company at the university, I would introduce him as, this is my son, and after a while he goes, Dad, I don't want to be introduced as your son. I want to be introduced as co-founder and CEO.
I love it. As parents, David and I know exactly what you mean. Our kids are probably a little tired of being the kids of the Jaspers. But Professor Torbert, we appreciate you so much. Keep working to come up with new things to make the world better. It is such a wonderful opportunity to talk to you. Thank you.
Well, it was great. Thank you very much.
Hi, everyone. I'm here with Dr. Marina Greene, and we are actually at the research facility in Ireland. And I'm really excited about that because I got to hear you speak at Bonn. It was incredible. And
Thank you.
I can't wait for you to tell everybody about the presentation and your research. But I also want you to start by telling them about you. And they're going to love your accent, by the way.
Thank you, Claire. Well, I'm from Mexico. I'm an internal medicine doctor. I did internal medicine in Mexico, and then I tried to pursue a scientific career, stepped away from the clinic to see other alternatives to mainstream medicine, and that's how I ended up doing a PhD in nutrition.
Wow.
With Professor John Nolan here at the Nutrition Research Centre Ireland. So that's why my accent is that mixture between a Latino and an Irish. Which was a little bit of fun during my presentation. I finished my PhD last year, and currently I am coordinating all health-related research conducted here at the Southeast Technological University in the School of Health Sciences.
Wow, that's incredible. So
Thank you.
I've heard you talk a little bit about a few different topics, but let's go right to the presentation that Dr. Greene did at the and you're a professor as well. So doctor and professor at Bonn.
So Well, I'm not a professor. Sorry, Claire. I'm not a professor. I'm just I have two doctors. I'm a medical doctor, an MD, and a PhD.
Okay.
Yeah. My presentation was a little bit of everything with a focus on clinical application from my medical perspective. So I think that was a difference that it made a difference from the rest of the presentations, which were all scientifically based. Mine was within the scope of carotenoids and all the science behind bioavailability, dietary patterns and nutrition, but with the under the perspective of clinical implications and applications. So how can we translate everything that we're doing into practice, and that actually can help current practice in both in clinicians and in patients.
So it's going to be a little bit difficult, I think, to take an hour presentation and break it down into just a few minutes. But what can you pull from that to help us today?
Yeah, well, I think the most important aspect to understand about my presentation was definitely we are what we eat. So it matters what we eat, but it matters as much how do we eat. So how are you eating all these carotenoids and these nutrients? It's been shown that we are not eating enough of the nutrients that we actually need, and we are eating too much of the things that we don't need, such as saturated fats and red meats and processed meats, and we're not eating enough of the good stuff, the fruits and the vegetables. Now, you can say, well, the message out there is eat your greens, eat your 5 a day. But it's not just eating them and consuming them. It's how we cook them, how we process them. Because if you have the salad, the raw salad with your green leafy vegetables, you're not going to fully absorb them. So most of it goes to waste. Now I'm going to be very specific here. I'm talking about carotenoids, lutein zeaxanthin and mesozeaxanthin, which they do need some processing to be released from the cellular, the cell membrane, which is very tough. They're released from the matrix, and then we can absorb them. So if just by cooking them, grinding them, anything that we can do to process our fruits, our vegetables particularly, would increase the absorption. Now, why does that matter? Because first of all, we don't take enough of them. And second of all, they are difficult to absorb. They are fat-soluble molecules, which means that they need a very intricate process to be absorbed. They need a proper micellization process, which means you have to grab these molecules and put them in a micelle, and all of this is done by our gastrointestinal system, our bile and our pancreatic enzymes. So that's a series of steps and processes that need to undergo, which complicates even further if you are not processing all your food correctly. So I think that was the first part of my presentation, which was key to understand. The second one was that dietary patterns are important. Dietary patterns matter. So having your salad with olive oil, for example, instead of a dressing. Processing it because so that's a very good question. If you have these nutrients with saturated fats, like French fries, the common thing that you have your burger and it comes with French fries, and then you have a little salad.
You think you're being healthy by getting the salad.
Probably you're not absorbing any of it, because all the fats from the French fries and the burger and everything are constantly fighting, and they will interact with the absorption. So you're better off just enjoying a cheat day or a cheat meal, and then at night or the following day just have your healthy salad and vegetables.
Wow, that's a good tip. and it's all in science. That's what's amazing about your presentation.
Oh yeah, absolutely. Everything is completely evidence-based. We've run clinical trials, and not just us as a research center, but there's a lot of teams out there that have done the research, have done loads of work on it. Other presentations that we saw by Dr. Antonio, Alex. They did great job in presenting this data that is already there. We cannot be so, and then there's genetics alterations as well. So you're dealing with your own genetics. You might not have the right enzyme, or you might not have the right transporter to absorb the nutrients. So all of these factors matter when we are actually choosing what to eat and how to eat it.
Yes. And as an internist, how do you wanted really for us to understand the science shows us that we are what we eat. And how do we then have that conversation with our patients?
Thank you for that question. It's very important because at the end of the day, we are the main cause of death worldwide is cardiometabolic diseases. And this is a cluster of conditions that share an underlying metabolic abnormality, which is abnormal glucose, abnormal lipids that leads to chronic inflammation and oxidative stress. If we can fight that with our own nutrition and we can prevent that from happening, is the most important message to put out there. So anybody that has any condition, an already established condition like diabetes or abnormal lipids or cardiovascular disease, they have an underlying inflammation.
Yeah.
So probably it's very, and then on top of that you have medicines that will also can interact with the absorption of this nutrient.
What is an example? Tell everybody.
So all probably cholesterol and all the drugs that are trying to lower the lipids in your blood might interact with fat soluble molecules, because that's what they're trying to do to counteract their effect of the bad fat. So it's saturated fats we're talking about. So if we can have a better nutrition with better nutrients, and nutrients that have shown antioxidant, anti-inflammatory capacity, is something that we should put out there for our patients.
Do you have, I guess the question everyone's going to have, I know where they're going with listening. So what do you use? What resources do you use to teach them the right things to eat? And then that's question one. The second question is, we can't tell them not to take their statins. Obviously, they need their medicine.
Of course.
So if they're taking supplements or if they're trying to eat right, what is the best time? Is there a time or a day? I mean, a time of day they should take the statins?
Yeah, well, that's
just one example, right?
Yeah, true. Well, I'm going to start asking your first question. Unfortunately, sometimes, and certain people, the patients that I've described, we cannot have all the nutrients that we need.
Yeah.
And that's when we, as clinicians, should consider supplementation.
Okay.
Now, nowadays, supplementation is regulated. It has to have, a certificate of properly being sourced and to state what they're to contain what they're really stating. That's very important. That you trust your supplements first of all, and then that supplementing is important. It's not an alternative indication or an alternative prescription to mainstream medicine.
Right.
I think is an addition to their statin. It's an addition to everything that mainstream medicine is doing.
Yes.
That will help and enhance their health. So I would definitely suggest supplementing in this particular population where you don't have enough nutrients, or you don't absorb them, or you might have genetic abnormalities or an underlying inflammation or a chronic inflammatory response, because we're simply not getting enough of them.
Right.
And then your second question about when and how, that's a good question, because again, they're so complicated that they will they're always interacting with other foods. As long as you're not having a meal rich in fiber, for example,
breakfast.
A lot of breakfast, your cereal,
oatmeal,
or a lot of fruit that's high in fiber.
Okay.
So we generally suggest to have them with your biggest meal.
Your supplements.
Your supplements,
okay,
so that they can absorb better. As long as you're not having a high fat meal
right,
with your French fries and your burger.
We have to assume people are eating well at least a few times a week.
Yes, exactly.
That is such good information. So
Thank
what
you,
would you say is your takeaway message? We kind of talked about eating right. Is there anything we left out that was the takeaway?
No, I think it's eating right, but it's also knowing how to eat right. So processing your foods, processing, cooking. There's misinformation out there that if you cook your vegetables, you're actually killing the nutrients. That's not true for carotenoids. We actually have to process the vegetables to break the walls and allow for the release of these nutrients into our gastrointestinal tract, and then so that we can absorb them. So yes, higher intake of fruits and vegetables, and processing your vegetables, and understanding that is a multifactorial situation. It's not just that you're not eating enough. It's that you're not eating enough and you're not absorbing them, and you might have some inflammation and some genetic problem with your enzymes. So all of that will lead to the fact that you might not have enough, and you are in this population where you have to supplement, and it's actually beneficial for you to supplement.
Thank you, Dr. Greene.
Thank you, Claire.
This is so helpful, and I can't tell you enough how much I know our listeners are going to appreciate the information. And thank you for all the research you do here. It's incredible.
Thank you very much. Thank you.
Before neural lenses, I always had eye strain,
eye dryness,
eye fatigue,
moderate to severe headaches.
I had to take prescription medication.
It was to the point where my kids, they'd want me to sit down and color or read them books, and I couldn't do nothing.
When I got my neural lenses, my headache went away.
I wasn't taking Tylenol anymore.
Can't explain it, but it worked.
I would pay double for my neural lenses because I can't go a day without them.
Welcome to Opt In with April Jasper. Dr. Jasper and her guests discuss hot topics, practice management tips, patient care moments, and vendor vignettes in this weekly podcast. Catch it simulcast on YouTube too.